Hi everyone, this is Tim, your Block 2 lecture instructor, and this PowerPoint is going to cover renal, which I found in your EG book. We're going to do chapters 68 through 71, roughly. I pulled out all the disease processes that I thought were important, and we're going to focus more on assessing your patient. You know, what symptoms did you actually find, and what are you going to do to actually fix them and fix the actual problem itself, and what the outcomes are going to be. So again, we'll follow the ADPI rule, which is going to be basically assess interventions and outcomes. I want to kind of preface by stating that, as I mentioned in block 1, that the kidneys, to me, are one of the most important organs of the body because it's all based on homeostasis. Your kidneys are going to constantly try to balance the difference between what's going on in your body and actually fixing it and getting rid of stuff. So whether it be electrolytes, whether it be a fluid overload, or being dehydrated, or poisons or toxins in your body, your kidneys are the ones that are actually filtering all that stuff out and keeping the balance within your body itself. I find that if your kidneys aren't working correctly, then a lot more problems happen, and whether it be your heart, your lungs, your brain, your liver, it really comes down to the kidneys functioning properly. So I'll kind of point those out to you as we go along. All right, so here we go. So we know that the kidney is actually used for urinary elimination and maintains bodily fluid volume and composition. And the kidneys also filter waste products for elimination. The kidneys also regulate blood pressure. They also balance the difference between acid and the bases. It also produces erythropoietin for red blood cell synthesis, and it converts vitamin D into an active form. So here's your renal system. We've got your kidneys, we get your urinary tract, we got your ureters, your bladder, and your urethra. So the regulatory function of the kidneys, the first one is going to be glomerular filtration. You also have tubular reabsorption and tubular secretion. So basically blood filters in through the kidneys. Your glomerulus actually filters that blood and finds out what it actually needs. If your body needs more water because your body is dehydrated, then your tubulars will actually reabsorb that. If your glomerulus actually filters the blood and finds that out that you are overly hydrated, then your tubulars will actually secrete that water to be able to pull it off. So again, it maintains the fluid and it also maintains the electrolytes and your acid-base balance. Again, homeostasis. So for the glomerular filtration, it will form urine, when it will compose of water, electrolytes, creatinine, urine nitrogen, and glucose. Your kidneys will actually produce and you will excrete 1 to 3 liters of urine each day, and that's based on being hydrated. So a normal adult that is drinking plenty of fluids and keeping themselves hydrated, your body will actually excrete 1 to 3 liters of fluid each day. If you're dehydrated, obviously that level goes down. But the glomerular actually does not filter blood cells, albumin, and proteins because these are too large to actually be filtered through. So if you have a patient who is having blood in their urine or albumin or proteins in their urine, then we know that they actually have a kidney problem. So for tubular reabsorption, reabsorbs most filtrate, which is water and electrolytes. So again, if you're actually dehydrated and your body is actually filtering your blood and pulling what it needs and trying to excrete what it doesn't, if it needs more water and electrolytes back into the system, then the tubular of your kidneys will actually reabsorb that water and electrolytes and put them back into the actual system. It keeps normal urine output balanced between 1 to 3 liters per day, and it prevents dehydration. So for your ureters, it's connected to the kidney to the bladder. It's 1/2 inch in diameter, and it's 12 to 18 inches long, and it narrows in 3 areas. This is where kidney stones usually get stuck. So if this works out correctly, so we have a narrowing here, here, and here, and possibly here. So myself, I actually have past kidney stones before and have had issues. So basically the kidney stones will form in the kidneys. They'll actually pass through, and usually in these narrow areas is where the cause of the pain is. And let's see here. So the urinary bladder, it's an internal urethral sphincter, and it also has a pudendal nerve. The reason why I bring this up is because you will have patients who actually have Foley catheters placed to actually help urine pass from the bladder out. That pudendal nerve is where the actual balloon of the bladder sits, and because of that, it actually makes them feel as if they have to constantly urinate. So for the ones that are really confused or are trying to get out of bed every 5 minutes because they're like, I gotta go, it's really because that balloon sits right there at that nerve, and it actually doesn't irritate it, it just gives them the false sense that they actually have to urinate, and it's because of that. And I bring this up because you will have a lot of patients, whether it be them being alert and oriented or not, they will have to feel like they have to go. And this is one explanation for it. So we have the urethra. For men, it's usually 6 to 8 inches long, and the bladder, it goes from the bladder to the prostate, to the pelvic floor, to the penis. And for women, it's usually 1 to 1.5 inches long. This is why most urinary tract infections happen in females instead of males, and it's because of the distance between the rectum and the actual urethra for women is so close together that it is a area that can cause infection. Whereas with men, because the urethra travels so far to get to the bladder itself, there's a lot of room for it to your body to kind of keep the infection rate down. So all right, so for lab tests, we have blood tests. It's going to be the serum creatinine, which is 0.5 to 1.2 milligrams per deciliter. It's produced when protein and muscle breaks down. It's filtered through the kidneys and excreted through the urine. Increases with kidney impairment and decreases with decreased muscle mass. So what basically happens is that the serum creatinine level is caused from muscle breakdown. So whether you have athletes or older adults, the actual act of muscle breaking down is what is causes the serum creatinine to either go up or down. Again, based on homeostasis, your body will actually correct these issues and will keep your serum creatinine level normal, which is 0.5 to 1.2. If those levels actually go up or go down, it's because there's actually a problem with the actual kidney. So for blood tests, you also have a blood urine nitrogen, which we call BUN, and it's usually 10 to 20 milligrams per deciliter. And this is actually a byproduct of protein broke down in the liver. So you eat a big, huge steak, your liver actually breaks it down, and that's what causes the BUN to actually go up or down. Excuse me. Now, based on homeostasis, your body will actually fix. Let's say you eat a big, huge steak, and your BUN and creatinine, or your BUN actually goes up to 21. Your body will actually fix that, and it will go back to normal. If you're having a liver issue, then it won't actually be able to produce homeostasis, and the BUN will actually go up. So if it is increased, it could be because of a liver issue or a renal issue. It could be because of hydration or dehydration or high protein in your diet. So the next test is going to be urine. We have a urinalysis. This is collecting of urine, and it can be first thing in the morning. Usually it's your first void. And what you're looking at is the color, odor, and turbidity. So you're actually looking at the urine itself. Is it clear? Is it cloudy? Is it have sediment in it? Is it too dark of a yellow? Or is it too light of a yellow? Is it amber? Is it blood tinged? I mean, there's a million different descriptions of urine. But you as a nurse, you're actually pulling the sample, and you're going to look at it, and you're going to smell it, and you're going to find out whether or not it actually has something wrong with it. The reason I bring this up is because I've had patients where they come in for one issue, whether it be cardiac, renal, pulmonary, it doesn't really matter, and they go to the bathroom and I think, wow, that really kind of smells pretty strong, and that could be because they're dehydrated, or it could be because they actually have infection. Again, you're looking at it to find out if it is cloudy. Cloudiness is a sign of infection. So again, as a bedside nurse, you're really kind of looking at it really just to kind of find out, well, is there really something wrong with it, or is it something else that needs to be taken care of? So we also have urine test, which is a specific gravity. This is the density of urine compared with water, which is 1.000. Normal specific gravity is 1.005 to 1.030. If this specific gravity lab is increased, it's because you're dehydrated. If it's decreased, it's because you have too much fluid intake. So let's go back to the picture here. So this patient right here, let's just say this is a normal clear yellow urine. If you drink too much water, it will actually become lighter. And because it's lighter, it's because you're diluting it. If you don't drink enough water and your body's actually just producing, or your kidneys are actually producing and filtering the waste, it will be much darker. So the specific gravity is actually finding out whether or not you're either too hydrated or not hydrated enough, and what you're actually pulling out, whether it be your electrolytes and your acids and everything else. The specific gravity also tests for pH. Normal is 4.0 to 8.0. Measures acidity and alkalinity. It also will test for glucose. Increased glucose is hyperglycemia. So for the patients that you have that are diabetics, they may actually have a specific gravity that has high glucose in it. If the glucose is way too high, then it will actually start to pass ketones, which are fatty acids, and diabetic ketoacidosis. Will also pass proteins. An increase will be higher than 0.8. This could be a symptom of stress, infection, or exercise. Red blood cells could be possibly from catheters, stones, tumors, or bleeding disorders. You normally don't pass this list of things. So if you do, you have to kind of go back and find out, okay, what is going on or what has been happening to cause them to do this. So let's just say that you have a young 25-year-old guy who's been exercising a lot. His specific gravity may actually show that he's passing proteins. And that's not necessarily a good thing, but you have a reason for the protein level to go up. If you have an 80-year-old grandma who you just placed a Foley catheter in, the trauma from the placement of the catheter in the urethra may cause her or him to bleed. So if you find red blood cells in a urine sample, it may be because of the actual catheter. A 40-year-old male may be actually passing stones, which also causes trauma to the ureters and the urethra. So that may be a reason why red blood cells are actually being passed. It could be a tumor, or maybe they're having a bleeding disorder. I've had people who are on Coumadin that their INRs are 6 because they've been taking too much for so long. They may start to actually bleed, and not excessively, but just enough that it's causing the red blood cells to pass through the urine. White blood cells that are found in a specific gravity will be a sign of infection, and nitrates that are found in a specific gravity is usually because of E. coli. And again, the distance between the rectum and the urethra for females is very close. So whether it's poor hygiene or possibly the catheter was placed, you try to do as well as you could by keeping it clean and placing it properly, but sometimes things just don't work out right. And but E. coli is a big factor in the bacterial infection down there, because it's warm and it's moist and it's a breeding ground for that. So diagnostic tests, you also could do a bladder scan. This is an ultrasound that you can do at the bedside. Basically, it's a little machine that you place on the bladder, and it actually will determine how much urine is in the bladder. You'll do this for patients who have urinated but feel that there's still something in there, or you'll actually have patients who feel that they need to urinate but they can't, and the bladder scan actually tells you if there's anything in there. If there is and they're not able to go, then you need to fix that problem. A CT scan measures kidney size and assesses for masses. An ultrasound measures the size of the kidney and detects tumors and obstructions. An MRI will determine stages of cancer, and a renal scan will show kidney flow and glomerular filtration rate. So as water and blood and everything else is filtered through the kidneys, if your glomerular is filtering correctly, then you'll have a good rate. If it's not, then it'll determine what that rate is and if it's not working correctly. All right, so we have cystitis and UTIs. So you have inflammation of the bladder. It's an infection caused by bacteria, viruses, fungus, and parasites. Cystitis and UTIs are infections that move from the urethra to the bladder. 90% of UTIs are caused by E. coli, because again, the distance between the rectum and the urethra are very close, and that's a breeding ground for this. Usually the UTIs are caused by this. Organisms grow in peritoneal area and move to the urethra, and 50% of patients with catheters become infected with 1 week of catheter insertion. So that's why in Block 1 we were stressed a lot to you guys about CAUTIs, catheter-associated urinary tract infections. We've had, and this has been going on for years. Patients come in for, one problem or one issue. For whatever reason, we have to place a catheter, and within a week, they actually have a urinary tract infection. And they didn't have one before, they didn't have one coming in, and for whatever reason, we gave them one. And it's usually because we either didn't clean the peri area, good enough, we didn't place it well enough, or we're not actually cleaning the peri area after a catheter has been placed, because this is a mode of infection, and so if we don't keep it clean enough, it's going to cause urinary tract infections, which will cause urosepsis. So it's an infection from urinary tract to the bloodstream. Essentially, it will go from the urethra to the bladder, and it will go from the bladder to the kidneys, and then from the kidneys it gets bad enough that the infection goes straight to your bloodstream. So for a physical assessment, you're going to look at the urine again. You're going to find out, is it cloudy? Is it clear? Is it foul smelling? Does it smell normal? And you're going to look to find out if it's actually blood tinged. So again, I can't stress to you enough, bedside nursing, you empty Foley's, you have patients urinate in urinals or into a hat, and you find, you're looking at it, you're smelling it, you're inspecting it to find out if there's something going on. If there is a suspicion based on your assessment, then you can actually do a lab. It's called a urinalysis and a culture, or a UA. You're testing for leukocytes, esterates, and nitrates. It will also test for bacteria, white blood cells, and red blood cells. This determines if the patient has a UTI and what drug it is sensitive to. So a sample can be obtained through a clean catch or through a catheter. If the labs come out that these are high, then your suspicion was right. You're now proving that your patient actually has a urinary tract infection. And based on what infection it is determining what antibiotic you're going to give your patient to be able to cure it, because not one antibiotic cures every UTI. So drugs could be ciprofloxacin, which we call the bedside Cipro. We have levofloxacin, which is Levaquin. We have amoxicillin and Augmentin. So we have urolithasis, which is colliculi stones in the urinary tract. We have nephrolithiasis, which is stones in the kidneys. You have urolithiasis, which is stones in the ureter. And everyone excretes crystals in the urine, but not everyone forms stones. Stones form in the kidney and pass into the ureter and lodges in the ureter bends. And damage from the passing stone can cause blood in the urine. So kind of got a little lost. We went from the urinary tract infections and drugs that will actually fix it to kidney stones. The reason why this is actually important is because if you're trying to pass stones and you can't necessarily excrete the amount of urine that you're normally excreting, urine can back up, and you can also get urinary tract infections from this as well. So stones in the ureters. You actually have a kidney stone, it passes through, it gets possibly gets stuck in the narrowing of the ureters, like we mentioned before. So we have a stone in the ureter here, and it actually pass through, and it actually goes into the bladder here. Now, the reason why I brought this picture up is because I have had kidney stones and have passed them, and usually it becomes painful from the kidney and into the ureter. Once it hits my bladder, the pain goes away. Usually they either get stuck there and they just kind of sit there forever and they don't bother me, or I will actually pass it through the bladder into the urethra, and that's where it also causes more pain. So passing kidney stones, your assessment for your patient is going to be severe pain. And let me tell you, they hurt a lot. Usually my pain starts in my back and it goes around my flank area and into my abdomen, and I don't necessarily have scrotal or testy pain, but the flank and the abdomen pain is usually where I have it. I tend to get nauseous. I don't usually vomit, but I usually get very nauseous from it. I don't necessarily get pale, but I will become diaphoretic. It's my body's way of telling me, hey, there is something wrong and your body's trying to fix a problem. Based on these symptoms, I know what that problem is. If your patient becomes allegoric or anuretic, this is an emergency. Basically what happens is that stone has gotten stuck somewhere between your urethra and your kidney, and the kidney, even though it's still filtering and still producing urine is not passing. At that point, they actually have to do something to be able to get that stone out, or it will start to affect your kidneys. So for diagnostic testing, you can do UA, which will find blood in your urine, or a white blood cell in your urine, which will be a sign of infection. For me, usually the diagnosis is that there's blood in my urine, but usually not a white blood cell count, because there's no infection. This right here is actually a picture of a KUB, and basically what it's done is it actually will show you what kidney stones there are and if they have gotten actually stuck somewhere. This one here actually shows that there are kidneys in the kidneys. There's actually kidney stones in the kidneys, and then this picture here shows where they're actually going down and they're actually making their way to the bladder, and they have gotten stuck in these areas here. A CT scan will also show the same thing. I've had a CT scan done before, and it has shown that I have had several kidney stones that are just sitting there waiting to happen, and usually they can kind of tell me how many there are. So when I do pass them, I'm like, okay, well, I went from 5 down to 4, and then a couple months later it went from 4 down to 3, and eventually it goes down to 1 or 0. Then you kind of think you're out of the woods, and then about a month later you pass another one. So it's not an exact science, but at least they can kind of show exactly where they are, how many you have, and what the plan is. So for managing pain, you can do drug therapy, which is going to be morphine, ketorolac, or Toradol, or Ditropan. For me, Toradol is my drug of choice. It's an anti-inflammatory. Basically, it relaxes all of the muscles and the ureters and my bladder, and it allows things to actually pass a little bit better. Morphine, it will take away pain, but it's really just taking away generalized pain, whereas the Toradol is anti-inflammatory. Non-drug therapy could be relaxation, repositioning, or a heating pad. I found that relaxation, for me personally, does not work. Repositioning does. If I get into a certain spot, I can actually lay down and kind of relax a little bit, but the heating pad does do a lot more. It actually relaxes a lot of my muscles, and it kind of makes things dilate a little bit more, blood flows a little bit better. And again, the other thing you can do for managing the pain is hydration. Patients who are prone to kidney disease or kidney problems or kidney stones should be drinking at least 3 liters or more a day. What this does is it actually keeps your kidneys flushing, keeps them open, it keeps everything moving, and when you do have stones, it kind of helps pass them along. It's like passing a stone through a garden hose. The more water you run through it, the faster it actually helps filter it through. So other interventions is lithotripsy. This is shock waves that break up the stones, and once you actually start to break up those stones, you're going to use these little cups here that will actually strain the urine, because if you can use the cup to urinate in and you find that you've passed a stone, then you know that the lithotripsy has worked and things are moving the way they're supposed to. If the lithotripsy doesn't work, you actually could do stents. Stents are, they can actually go up through the urethra, into the bladder, up to the ureter. They actually can put the stent in, and what the stent does is it opens up the ureter so that way the stone can pass through it. They can also do a retrograde uroscopy, which is basically the picture here, where they go up through the urethra into the bladder, go up to the ureter, find the stone, they grab it, and they literally just pull it all out. The lithotripsy doesn't hurt. The stents and the retrograde, those don't necessarily hurt per se, but the process itself is uncomfortable. But again, you're in so much pain that these two things, once they're done, you feel much better, so it's worth it. All right, so the next disease process is pyelonephritis. This is a bacterial infection in the kidney and renal pelvis. Acute is an active bacterial infection, and with chronic, this is from your repeated urinary tract infections. So for an acute patient, basically this is a UTI or some sort of infection that has now affected the kidneys themselves. With chronic, it's really just the repeat of all these things. Or it could be a defect, it could be an obstruction, or urine can actually back up from the bladder into the ureters and actually start to affect the kidneys. Abscesses are anywhere that are in the kidney itself, and it can also cause pyelonephritis. So the assessment of pyelonephritis is fever, chills, tachycardia, tachypnea, flank, back pain, loin pain, abdominal discomfort, nausea, vomiting, and recent treatments of UTIs. So for pyelonephritis in this picture, it basically is little inflammations, or it could also be little pus pockets or abscesses. Basically, it's anything that's actually happening to the kidney themselves. It's affecting the actual organ. So for the labs, you can do a urinalysis, which will show leukocyte esterase, white blood cells, bacteria, red blood cells, and proteins. Blood cultures will also show a C-reactive protein and a erythrocyte sedimentation rate. So the difference between the UTIs and actually trying to diagnose those and this is that the blood culture itself will actually show a C-reactive protein and will also show that the actual sedimentation rate is high, which is a sign of infection. Why they don't just do this first, it's because you're really trying to use your assessment skills, try to diagnose something that you think may be happening. The urinalysis may show these things, but the blood culture is actually more of the, the standard for pyelonephritis. So diagnostic testing for pyelonephritis is going to be your X-ray or your KUB. Here are pictures of your kidneys, and kidneys don't normally look like that, so it's these parts right here that is the pyelonephritis. So for treatment for pyelonephritis is going to be managing the pain. You do pain meds, which could be anywhere from Percocet to morphine to Dilaudid to Vicodin, things that are actually going to cause pain, because it is pretty painful. Or it could be non-surgical, which could be antibiotics, because again it is an infection. Nutrition, because if you're not eating correctly, your body's still trying to process. Your kidneys are trying to filter that stuff out. A good nutritional diet will make this a little bit easier. Alright, sorry about that. So anyways, we have the nutritional therapy, we have fluid therapy. So again, the more hydrated you make your patients, the faster things can actually either resolve themselves, or it just makes the process a little bit better. We also have surgical treatments, which is actually to remove the problem. Now, I'm not quite sure if that's actually to remove the kidney itself, because you can live with just one, or you can also do surgical removals of abscesses within the kidney itself. All right, so the next one is going to be renal failure, chronic renal failure. So this is a progressive, irreversible kidney disorder that does not recover. I want you to know these, 1, 2, 3, 4, 5 stages of the kidney's loss of function or the failure. So stage 1 is going to be that you at least still have a glomerular filtration rate of 90. The cause can be hypertension, diabetes, chronic UTIs, or genetic kidney disease. Basically, your kidneys are still functioning, but the secondary issues are what's causing the kidney problems. With stage 2, you have glomerular filtration rate of 60 to 89 milliliters per minute. Again, the hypertension, the diabetes, medications, and there's a million different reasons why your kidneys could be failing. And the stage 2 is just an extension of stage 1. It's just the glomerular filtration rate is less. With stage 3, it's the 30 to 50 milliliters per minute, and the only thing you can actually do at this point is really just slow the disease process. You're going to probably treat more symptoms and other problems, but you're not going to be able to really fix the kidneys. With stage 4, your glomerular filtration rate has now gone from 15 down to 15 to 29 milliliters per minute, and all that can be done is really just to, again, manage the complications and prepare the patient for a kidney transplant. With stage 5, it's the end stage. It's where your kidneys literally are just not working, and the only thing you really can do at that point is really renal transplant, which is your kidney transplant, or you can actually remove the kidney itself, or you can put them on dialysis. And here's a wheel that shows the different stages and the different glomerular filtration rates. So for kidney changes, we got reduced glomerular filtration rate causes. This could be abnormal urine production, it could be poor waste excretion, electrolyte imbalance, metabolic abnormalities, creatinine increases or bun increases, and urine output decreases causing fluid overload. So the reduction in glomerular filtration rate causes these issues. So if your kidneys aren't functioning properly, your creatinine and bun are definitely going to increase because it's not able to actually process them or filter them well enough. The electrolyte imbalance is going to be increased because instead of your kidneys being able to flush out what it doesn't need, it just holds on to that stuff. And again, the poor waste excretion is really because the kidneys aren't able to get rid of that stuff. So for electrolytes, your sodium will increase, your potassium will increase, acid excretion is reduced, causing metabolic acidosis, which we'll cover in another chapter. We have calcium, it decreases because it causes bone loss, and then phosphate increases. So for those of you who remember VCE, we had a patient who had kidney issues and their phosphate was high, and usually it's because of the food that they eat and the things that they drink, especially carbonated drinks like Coke or Pepsi or whatever. Those are high in phosphate. So for kidney patients, you definitely have to start to watch what they eat and what they consume, because if the kidneys aren't able to really process it, you're really just adding more stuff to it. So for cardiac changes, chronic kidney disease could cause an increase or worsening of hypertension. That's because of the sodium retention and the fluid overload. There will become hyperlipidemia, which increases the triglycerides and the total cholesterol. And it could also cause heart failure because of the increased workload of the heart because of the hypertension and the sodium retention and the fluid overload. So if hematological changes, it will decrease red blood cells and platelets, because again, your kidneys is what actually produces erythropoietin, which is a ingredient to increase red blood cell production. Another hematological change will also increase anemia, because obviously your body's not producing the red blood cells that it needs. So for physical assessment of chronic kidney disease, for neurological, it's going to be lethargy and drowsiness. For cardiovascular, it's going to be hypertension, peripheral edema, and heart failure. For respiratory, it's going to be tachypnea, pulmonary edema, and pleural effusion, crackles. For hematological, it's going to be bruising and bleeding. And for GI, it's going to be nausea, vomiting, diarrhea, and GI bleeding. All right, so let's make this simple as possible. You have a patient who has chronic kidney disease. We know that the kidneys are not working properly. We know that them not working properly and filtering what your body doesn't need, because it's constantly trying to cause homeostasis. If it holds on to all the things that your body doesn't need, you're going to have issues. So those issues are going to be, for neurological, it's going to be the lethargy and the drowsiness. We know that if your body does not flush out what it doesn't need, which is going to be fluid, sodium, potassium, it's going to cause hypertension and the edema and the heart failure, because all your body has done is actually held on to all the sodium and waterfall salt, so it's going to hold all that stuff in. For respiratory, because the fact that it's held on to the sodium and the actual fluid, it's going to cause your patient to have to increase their breathing. The fluid has to go somewhere, and because of that, a symptom is going to be crackles. It makes their lungs very moist and very wet. We know that the kidneys also produce erythropoietin, which is helping the body produce red blood cells. If that is impaired, then your body isn't able to actually produce the red blood cells. Well, it also will cause the platelets not to function properly, which would cause bruising and bleeding. With GI, you're going to have the GI bleeding because of the plasma and the platelets, and you're going to have the nausea and vomiting, the diarrhea, because of the fluid overload, the hypertension, hypertension, the pulmonary edema. So it basically comes down to the kidneys not being able to filter all these things. Things get backed up, and it literally just affects every system. So if you just look at it in the sense of head-to-toe assessment, what is normal becomes abnormal. For urinary, you're going to have polyuria, which is an early sign. You have anuria, which is a late stage. So for the early stage, you're going to try to, your kidneys are going to try to filter and do what it can. Your body's going to try to produce the homeostasis, and you're going to try to pee as much as you possibly can. In late stages of chronic kidney disease, you're just not producing any urine, so you just won't be able to urinate. It will cause protein in the urea. It will also cause hematuria. In the early stages of chronic kidney disease, your urine will be very diluted, and then in the late stage, it'll actually be very concentrated. For skin, you're going to actually have a decreased skin turgor, dry skin, and ecchymosis. For musculoskeletal, you'll have muscle weakness and cramping, and bone pain and fractures, because again, your body is actually not able to keep the calcium and the things that are normally, well, it throws things off. So as far as labs for sodium, potassium, phosphate, and calcium, phosphate, sodium, and potassium, those four are either going to be way too much or not enough, and that's what causes your musculoskeletal problems. So for labs, if you go to page 1543, box 71-2 in your IGGI book, so let me go there real quick, 1543. Let's see here, 1543, 71-2. Actually, page 1542, chart 71-2. These are your normal labs, and it also shows values in kidney disease. So I want you to really pay a lot of attention to this box, especially the serum creatinine, the BUN, your magnesium, your calcium, your blood pH, hemoglobin, hematocrit. Those are going to either be important in this chapter, or you're going to need them for your acid bases. So definitely kind of memorize as much as you can for that book. So it's definitely page 1542, 71-2 in your IGGI book. So let's see here. Once your kidneys have failed, you actually will go through hemodialysis, which is HD. So for end-stage kidney disease, dialysis removes the excess fluids and waste products. It restores chemical and electrolyte balance. It removes the fluid overload that does not respond to diuretics, and it also will help fluid overload, which will cause pericarditis and uncontrolled hypertension. So for dialysis, let's see if it's the next slide. There you go. So for dialysis, basically it's going to pull out the blood, it's going to filter it through this machine, and it's going to take what it doesn't need, and it will put it back into your system. So it will actually take all of your high values, lab values, and actually make them right and put them back into you. So dialysis can be done at in the hospital, in a clinic, or at home. Your patient either can do it every day. They may do it Monday, Wednesday, Friday. They may do it Tuesday, Thursday, or Saturday. And this is going to be based on their diet, their fluids that they intake, what kidney function they still have, and how their body actually processes all these things. Usually, in my experience at the bedside, patients either do it Monday, Wednesday, and Friday, or Tuesday, Thursday, Saturday. Let's see here, blood flows in, it's filtered, and it's returned. Heparin is given to prevent blood clots. It is active 4 to 6 hours. The reason why I bring this up is because your patient will go to dialysis, they'll filter all their blood, they give them heparin because it has the potential of clotting during the dialysis process. When you get them back, you have to remember that they have some sort of blood thinning property in them, so you have to watch out for the bruising, the bleedings, them bumping into things, them shaving, them falling down, all these things. So it's a little bit of anti-clotting drug. It lasts for 4 to 6 hours, but again, if they're doing it Monday, Wednesday, and Friday, they may be bruising and bleeding more often than not. So for vascular access, you have an AV fistula, which is an arterial venous fistula, or you have an AV graft, and here's a picture of it. You have radial and brachial arteries and veins are used. So basically they take the radial and the brachial arteries and veins, and they basically suture them together. It takes 4 months to actually mature. You should feel a thrill, which is a vibration, or you may hear a bruit, which is a swishing sound. The artery is used to pull off the blood, and the venous is to return the blood. So in this picture right here, basically what they've done is they've actually taken the artery and they've actually surgically put it together with the vein, and basically, let's see if it's the next picture. Nope. Basically, they actually take this, and again, the needle will, there's two needles. One will actually go into the artery, one will go into the vein. The artery will actually produce the blood to go into the machine, and then once the machine filters all the blood, it will actually put it back in through the actual vein. But that AV fistula and that AV graft, for your assessment, you will actually feel a thrill, and you will actually hear a swishing sound, which is the bruit. It's kind of, for me, it's interesting, but it's creepy. So, but anyways, that's me. All right, so precautions. There are going to be no blood pressure in the arm with the AV fistula or graft. There will be no IV in the arm with the AV fistula or graft. And that's because with that AV fistula or graft, by doing blood pressures or with IVs, you can do damage to those grafts themselves. You don't ever do an IV in an arm that has an AV fistula, because if the IV infiltrates, you can actually cause a lot of damage to that fistula or that graft. These people live because of the AV fistula, and they only have certain areas on the arm, and you only have two that they can do. And this has to last the rest of their life. So if you're 20, 30, 40 years old, they could either, one could last you forever, or you may have to go every couple months and get a new one. So eventually, having 20 or 30, 40 years left of your life and running out of room, you may cause more damage. So you don't do blood pressures or IVs in the arms that has an AV fistula or graft. You're going to assess it every 4 hours to make sure that it actually still works. You're going to assess circulation distally. So if you have an AV fistula or graft in your upper right arm, you're going to test the strength, the pulses, the sensations in the right hand. You're also going to check the pulses and stuff radial pulses and stuff in the right arm, because you want to make sure that the AV fistula in the right upper arm isn't causing damage to the lower part of the arm, or make sure that there's actually proper circulation. You encourage range of motion exercises because it keeps the muscles strong and also keeps circulation in that arm. You're going to check for bleeding at the needle insertion site, because again, they're getting heparin, so you want to make sure that the actual bleeding has stopped after they take the needles out. And you're going to assess for infection, because again, they're putting needles into those veins and arteries. They will clean them. They'll make sure that they're nice, clean, dry, and intact, and that they're, pretty much, it's not sterile, but it's a procedure you want to make sure that it's very clean. And when that's all done, you want to make sure that there is no sign of infection from that. This right here is actually a scar from an AV fistula. So basically they take a vein and an artery and they sew them together, and that's what the AV fistula is like. And usually they'll take a needle, and I think it might be the next picture. Yeah, there we go. So for temporary access, basically it's this red port here and this blue one here, and that's what goes in here. So basically a needle goes here and a needle goes here, and basically it goes, it pulls the blood out, filters it, and puts it back in. So now for temporary access sites, this is for people who actually still have some renal function, and they're hoping they may be able to actually fix it by, whether it be medications or other means to be able to get the kidney to function back to normal. Catheters can be placed instead of this. They can actually put in this catheter, which actually goes up. Let's see, here was where they put that in. It looks like they went through the intrajugular. Basically, they go through the intrajugular vein, and it goes into the top of the atria of the heart. So they could do subclavian, they can do intrajugular, or they can do femoral. One line will have a blue cap, and the other one will actually have the red cap. One is, let's see here, the red cap is pulling the blood off, which should be arterial blood, and then it gets filtered, and then it goes through the blue cap, which is the venous. And that's important because that way you know that if a cap comes off, what kind of blood is either coming out, or you want to be able to make sure that these are as clean and as sterile and working as properly as they possibly can. All right, so for nursing care, prior to dialysis, you want to be familiar with the drugs on page 1563. So let's see here, 1563. It's going to be box 71-12. The reason why I chose this box is because as a bedside nurse, your patient will usually go to dialysis Monday, Wednesday, and Friday, or Tuesday, Thursday, Saturday. Usually they start them off as early in the morning as possible. So you may still have the patient when you get there. And let's say they go to dialysis at 9 in the morning. Well, if 9 o'clock meds are due, you can give them their meds before they actually go. But if you give them the meds that are in this box, that dialysis machine will actually filter those drugs out, and they didn't do them any good. So you want to make sure that based on these meds. Now, I don't want you to expect you to memorize every med, but I want you to be familiar with the idea that there are certain meds that if you give them the meds before the dialysis, that dialysis may actually filter all through, and it didn't do them any good. So after dialysis, you're going to assess for hypotension, headache, nausea, vomiting, malaise, and muscle cramps. And the reason why is because with dialysis, they're taking off the blood. They're actually filtering it. They're taking off all their electrolytes. They're taking off all the excess fluid, all the water, all the things that their body could, or their kidneys couldn't already filter. It's going to filter it all out and put it back in. Well, it's going to try to balance it as much as possible, but it's not exact science. So your patient may have hypotension because you pulled off too much fluid. They may have a headache because of that. They may have nausea and vomiting, also because of the lack of fluid. Or they may have muscle cramps because you pulled off a lot of those electrolytes. So what you're going to do is you're going to check vital signs. You're going to check the blood pressure, temp, heart rate, and weight. Blood pressure is way too low. You may have to give them something to increase that blood pressure. You may find they may have a little bit of a temp. That might be a sign of infection. Heart rate may be really high because the fact the blood pressures may be a little low, and that might be a symptom of shock. So you're really doing a lot of assessments to find out where they are, try to fix those issues, and then determine whether or not it's normal for a dialysis patient or if there's actually a issue that you need to correct. So, besides dialysis, your patient can also do peritoneal dialysis. This is an exchange of waste, fluids, and electrolytes in the peritoneal cavity. There's 3 phases. You're actually going to take the dialysis solution. You're going to fill them, your patient. It's 1 to 2 liters of dialysate infused by gravity within 10 to 20 minutes. So basically your patient lays down. You actually take this solution here. It's actually going to go into their peritoneal cavity. They call it dwelling. It's basically going to sit there for about 6 hours. It's going to actually pull all the fluid and all the electrolytes and things that your kidneys couldn't do. And then it's going to actually then drain. And it goes from here out. And they're actually, excuse me, they're actually, you do this, I believe, every 8 hours. I have done it a couple times. It's not a very common procedure, but it's still done. And it's for those who actually have some sort of life and still are active. Patients who have dialysis Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, they still have a life, but they're confined to a chair or into a machine every other day for 3 to 4 hours based on how much fluid they have to take off. Whereas with peritoneal dialysis, the patient can learn how to do this at home for themselves, and they actually could do it at night while they're sleeping, or they can actually doing it during the day, but they can, they can do it when they need to do it, but they can still do it around their activities throughout the day. So complications of peritoneal dialysis can be peritonitis. This could be caused by site contamination or not using sterile technique. This port right here actually connects the actual tubing to the peritoneal site itself. And if that becomes contaminated, then that actually can cause bacteria to go through that line and into their body, which causes infection. So you do use sterile technique. Basically, it is a port that has a cap to it, and that cap has iodine infused into it. And basically, you clean it as much as you possibly can, and you actually use sterile gloves, and you actually put this cap and this port together. Symptoms of peritonitis will be the diastole, the fluid you actually put into them. The stuff that comes out will be cloudy. Your patient may have a fever. They may have abdominal tenderness and pain, and you will send this actual specimen to the lab to find out if it truly is an actual infection or not. If you are getting fluid off of them, so let's go back to the picture, if fluid goes in and then it comes out, if that flow coming out is not real good, it may be because of constipation. Right here is their intestines. They also have their bladder, and they also have other, they have other things there. So it's just a body cavity that's filled with a lot of stuff. The fluid goes in, it kind of swishes around a little bit, it takes what it needs, and then it comes out. So if the flow is poor, it could be because of constipation, or the actual port or the line itself might be a little clogged. So that might be another reason. So for nursing care, you're going to assess vital signs prior to the treatment. You're going to do their weight, which is a dry weight, which is weight prior to putting in the actual diastole. You're going to observe outflow. There should be a continuous stream. And you're going to monitor inflow and outflow, because again, you want to make sure the diastole goes in, and it goes in right, should be able to continuously stream into them. It should be able to sit for about 6 hours without having any issues, fevers, nausea, vomiting, blood pressure increases. I mean, you want to make sure that they're normally doing okay. And then you're going to actually monitor the outflow, make sure that's nice and clean, it's actually coming out the way it should, and then they're not actually having any issues or pain or abdominal tenderness or bloating or anything like that. So when all this has failed, you're going to possibly have a patient who's going to have a kidney transplant. This is a candidate that must be free from medical issues. So a person who's going to receive a kidney cannot have cancer, diabetes, HIV, anything that could possibly be another reason that they may die. Because even if you give them a good kidney, something may end up happening and they may end up passing anyways from a secondary issue, or actually a secondary diagnosis. So you want to give these two as healthy as individuals as you possibly can. Person to donate a kidney, they also have to have no diseases, no infection, no cancer, no history of cancer, no HIV, no hypertension or kidney diseases, and they must have adequate kidney function. So basically you're trading off one good kidney to a patient who needs one who is in as good as health as they possibly can be. So it's pretty simple. Kidney transplant, post-op, you're going to do a physical assessment. You're going to look for kidney function. You're going to provide immunosuppressive therapy, which is going to be drugs. You're going to monitor the input and output, making sure the kidney functions. You're going to do daily urine specimens to make sure there's no sign of infection. Complications from a kidney transplant could include rejection, tubular necrosis, thrombosis, renal artery stenosis, and surgical wound healing problems. So, and that seems to be about it. I know there's a lot of slides. This is roughly running about an hour. Hopefully you can hear me okay, and that's about it. So bring all your questions to class. Let me know if you need other help. And I think that the other couple of chapters or PowerPoints that follow this will help kind of concrete some issues. So let me know if you need anything. Thank you.